And now I can share. All right, hello and welcome. And thanks everybody for joining us for our first ever Diabetes Action Canada Research Network session, Research Network Action Session. I'm Tracy McQuire. I'm the Executive Director of Diabetes Action Canada, and I'll be moderating today's session. This session is all about keeping our community informed and engaged, and we'll explore how the work of our network is put into action for both research and community-driven initiatives to support our members in translating diabetes research into meaningful real-world impact for those with lived and loved experience in diabetes. I'll be starting today's session by sharing a brief update in three key areas where our team provides expertise and support to research. So the first is in patient engagement, then some knowledge mobilization updates, and then finally a digital health update. And then we'll hear from Dr. Diana Sherifali, who will share insights on her work in diabetes remission, followed by a discussion. And after that, our Director of Patient Engagement will provide an update on a patient-led initiative in collaboration with our patient advisory group called the Diabetes Community Hub. To make sure everyone has access to today's updates, we'll send a follow-up email with key highlights, which will have useful links and a recording of the session for today so that if you can't attend live, you can always come back to the recording. And throughout the session, we'll be keeping an eye on the chat, but we kindly ask that you hold your questions until the dedicated question and answer time. And until then, we thank you for listening on mute. So thank you for being here, and I look forward to the conversation. So I'm going to quickly start by passing it over to, passing it over to I'm actually going to go through the agenda, which I just did. So I'll quickly go over the times. So again, the welcome, then the knowledge sharing session with Dr. Sherifali, the interactive discussion, and then we're going to move on to the community hub. So I'm going to now pass it over to Lindsay to talk a bit about our Research to Action Fellowship and update everybody on the progress of this work.
Thanks so much, Tracy. It's really nice to see ACM, one of our partner organization representatives, actually in the room today that worked with us on the fellowship. So a quick overview. Last year, we ran the first ever DAC Research to Action Fellowship, a paid program for patient advocates, those with lived and loved experience of diabetes, to work with us over a period of 9 months to receive training in things like research process, communication, advocacy, everything from how to read a scientific article. And then they were paired up in teams of 2 alongside a partner organization with the goal of taking published peer-reviewed research and transforming that into modes and mediums and knowledge products that would work for their community. So in the first inaugural cohort, we had 8 patient fellows. They range from coast to coast to coast. We actually had over 70 applications for the first program, and the ages of the applicants were 18 to 70 years old plus. Super diverse group. Over 30% of the applicants were Indigenous. We had an equal number of folks that were male and female for the program, which was huge because we often see that in these spaces, we struggle to get male advocates telling their diabetes story, but it was really nice to have that diversity and parity this time. The group of 8 fellows worked in teams of 2 with 4 partner organizations. So one of them was Access Alliance, who's in the room with us today. And we also worked with NIDA, the National Indigenous Diabetes Association. We worked with the Diatribe Time and Range Coalition. And we also worked with Obesity Canada. Each pair of 2 fellows worked with DAC as well as their partner organizations to take 26 peer-reviewed published papers over their fellowship journey with us. And they created 4 projects. So one project was advocacy flashcards for Indigenous self-advocacy in healthcare settings. There was comics illustrating patient interactions for folks that live in larger bodies, culturally relevant vignettes for South Asian and Black communities, and infographics on mental health and diabetes management. So I'll just ask Yeah, perfect. So a little bit more about each of these projects. The self-advocacy flashcards for Indigenous communities are a set of 8 color-coded cards that not only were designed by our 2 fellows, but each team of 2 fellows were supported in leading a community co-design session by DAC. So we engaged Indigenous folks from coast to coast to coast to co-design these flashcards, and even employed an Indigenous artist with lived experience of type 2 diabetes to do the art for the flashcards. What's really neat about this set of cards is while it's made by Indigenous community for Indigenous community, anyone can use them, and the topics were also validated with folks that aren't Indigenous and are applicable in multiple patient and healthcare settings. The next project, the comics on patient healthcare interactions, led by our fellows Al and Matt. They worked with Obesity Canada to create 2 comic book stories. Each of them told their story in a comic book fashion of when they had been stigmatized in healthcare interactions. And then they flipped the script. We've seen that research shows that it's great to tell patient stories, but it's even more powerful to tell them with how could they have gone better. So they illustrated their stories in comic book fashion and then re-illustrated them again with advice for healthcare practitioners on how it could have been less stigmatizing and what could have gone better. The third project, the culturally relevant vignettes for South Asian and Black communities. You'll see on your screen, they were a set of 5 South Asian and 5 Black vignettes where the characters, the names, the content were all culturally relevant for their respective communities. We worked with Access Alliance and their set of community-led research data, as well as multiple community members, both from the Access Alliance network, but also our spaces, to co-design these set of vignettes with Cindy and Sanaya, our Access Alliance fellows. And last but not least, we work with the Diatribe, a Time and Range Coalition, to create 3 sets of infographics led by Natalie and Jeremy on how to manage your mental health while using CGMs. What was really neat about this is in the co-design session, we had an equal makeup of folks with type 1, type 2, and gestational diabetes, all with CGM experience. The best part is that we are now ready to share all these resources. So once I finish chatting here, I'll put the website in the chat. We're doing a very soft launch over the next couple weeks with our new resource library online, and you can learn more about the partner organizations, the fellows, and download the projects themselves.
Thanks, Lindsay. I'm going to do a quick update just to let everybody know about some of the work that's happening with our knowledge mobilization team. So earlier in February, we ran a webinar about our new KMAP tool, which is our knowledge mobilization action plan tool. This webinar, I'm going to send the link out afterwards, but really dives into how to use the tool on the right-hand side for when you're applying for grants and helps you plan out your KM for the before, during, and after a research project. So again, I'll also share the KMAP tool itself, and it's a good note to say that this tool has been used in a variety of different applications, including the most recent one with CIHR and INMD. So we're really happy to see some of this work collaborate with our CIHR team. Our next is going to be just on the digital health. So if you're monitoring your emails and all of our updates, you'll see that we have now launched Diabetes Research Connect. This is a rebranded opportunity and collaboration with the Canadian Primary Care Sentinel and Surveillance Network to give access to primary care data for our researchers. We have over 150 primary care providers covering more than 2 million patients across 8 provinces and 1 territory. This allows anybody who wants to look at primary care research the access to do so, and the access for this data is entirely patient-driven. So we have a governance group that looks at whether or not the research projects are relevant and meaningful to the patient community, and then approves if it is. So how do you use this data set? Lots of people ask. We've just added to our website 14 peer-reviewed publications that have used primary care data set. First, it was called the National Diabetes Repository, and now it is called Diabetes Research Connect in collaboration with CIPSN. And we'll be also sending this link after today's session. But now it is time to go into our research session. So I'm going to quickly introduce Dr. Diana Sherifali. So, Dr. Sherifali is a leading expert in diabetes research and clinical practice and is dedicated to optimizing diabetes management and improving the quality of life for individuals across the lifespan. As an associate professor and a researcher at McMaster University, her work focuses on empowering individuals to effectively self-manage their condition and mitigate its impact on daily life. Diana Sherifali's research explores health coaching and digital solutions to enhance diabetes self-management and improve health outcomes. Through her commitment to evidence-based care, patient engagement, and innovative interventions, she continues to shape the future of diabetes prevention and management in Canada. And I've noted she's a very active member of our network. And I put here some of the stats that she has with our network. So she's been with us since 2019, and we're happy to have her. She's published over 8 peer-reviewed publications with our network. That's not her whole CV. There's many, many more to that, but 8 with our network, and has secured 9 grants in collaboration with Diabetes Action Canada. So I am now going to pass the floor over to Diana. I'm going to stop sharing my side so then she can start sharing hers.
Okay. Thank you, Tracy, for that kind introduction. And now for the clunky part, I will make sure this works. And so if everyone can just confirm, just show thumbs up or something that they are seeing my perfect. Okay. Alrighty. Okay, so thanks again to Diabetes Action Canada for the opportunity to present today. It goes without saying, I am standing on the shoulders of many giants as I embark on this presentation. So what I'd like to do is just sort of talk a little bit about an implementation and knowledge mobilization opportunity that arose over the last several years, of which Diabetes Action Canada has been instrumental in sort of informing, guiding, but also supporting us in our approach to get funding to promote type 2 diabetes remission. And so the agenda for today is to take a step back and look at the evidence, look at type 2 diabetes remission implementation in primary care, one of the studies that myself and Dr. Zubin Puntaki are leading, and then type 2 diabetes remission evidence as this continues to grow this field and the opportunity for knowledge mobilization. Okay, so in terms of diabetes remission evidence, we know that this field is expanding rapidly. Um, we know that type 2 diabetes can be partially or completely reversed. Strategies vary. We can think of strategies sort of in 3 big buckets. There's non-pharmacological approaches. People will call those lifestyle. We'll talk a little bit about pharmacotherapy approaches, and of course, there's surgical approaches. So we have learned a lot from the bariatric surgery world, but for the purposes of this conversation today and this presentation, we're really going to focus on the non-pharmaco and then the pharmacotherapy approaches. I think what's really remarkable, and this was stunning, I just uncovered this not too long ago, is that there's over 100 definitions of diabetes remission. And we have some folks on the call that have participated in the EASD and ADA consensus definition of type 2 diabetes remission, but we also have some folks that have participated in Diabetes Canada's definition. This is not what this presentation is about. It's more about how do we move the conversation forward in terms of implementing diabetes remission so that it's accessible and equitable. Okay, so I got involved in a really dynamic, innovative, trailblazing team in a very, very small role. And that is a small role that I had around health coaching and building some capacity with folks that were acting as health coaches in several pan-Canadian clinical trials. So I would say over about 8 to 10 years, a Canadian team of multidisciplinary investigators led by 3 lead investigators, Doctors McInnes, Puntaki, and Gerstein, out of McMaster University and the Population Health Research Institute, have really forged our evidence and understanding as it relates to a multimodal approach. So it's a non-surgical approach, but it endeavors to lean in and use a multimodal approach. It's not just nutrition or diet. It's not just exercise. It's not just drugs, but it's a combination of approaches. So there were several studies that were done. All 5 trials, including the pilot trial, tested the efficacy of this induction period using key strategies that we see around the wheel to aim to reduce glucotoxicity, too much glucose, and drive glucose levels down to what's called that normal glycemic range, and see how long people can stay in that range following that induction period. And so the secret sauce of that intervention included frequent health coaching. So in some instances, people are contacted twice a week by a health coach through that induction period. And then they're also given metformin, basal insulin, and these therapies have been tested along with other metabolic choices, medications like DPP-4s, um, uh, uh, GLP-1s, and such. So an SGLT2 inhibitor. And in all instances, you can see underneath the sort of remit logo, we see hazard ratios. So in other words, in all 5 trials, these glucose lowering drugs and this combination of cocktail actually supported people to go into remission and lowered the hazard of relapse in the intervention group by anywhere from like 0.6 to 0.57 in comparison to the control group. And then subsequently, there was a lower hazard of diabetes relapse overall in the intervention group when compared to the control group. So in this instance, I think it was fair to say the combination of the various metabolic interventions, those different drugs, the SGLT2s, the DPP-4s, the GLP-1s, in combination with routine use of metformin, insulin, nutrition, exercise, and health coaching really was a game changer in terms of how we were thinking about type 2 diabetes remission. And so in consultation through some work that I had the pleasure of leading with a team from Hamilton Health Sciences to look at sort of service blueprinting, how would we scale this up and implement this, particularly with the use of technology, something that really rang true quickly was we needed a toolkit, if you will. We needed to know how to deliver this to a site where we're most likely to find people that are relatively new in their type 2 diabetes trajectory. And that was in primary care. So if there's one thing we try to have a friendly competition about, it's looking at acronyms and cool, catchy names. So I don't know if I was into Transformers or whatever the movie was, but I came up with Remit Prime, diabetes remission in primary care. And so we applied for some funding. We were grateful and very thankful and lucky to get funding from Diabetes Canada. And so after some consultation with some community partners, we found a very engaged and enthusiastic group out of Hamilton that fit under the Hamilton Family Health Team umbrella, and that is Escarpment Health Center. And so with this work, we hope to, first and foremost, learn how to implement this intensive diabetes remit protocol in primary care. We also want to understand the barriers and facilitators in implementing this from a patient but also provider perspective. Is this realistic? We also want to assess the clinical effectiveness of the Remit Prime intervention. If we're taking this out of sort of the clinical trial atmosphere and putting it in primary care, what does it look like? Does that intervention still hold? And then we want to utilize the findings to inform additional implementation sites. And we already have several sites across Cambridge and London, Ontario, that are quite excited and waiting to sort of come on board with some additional funding. And so this slide is a little bit busy, but I basically want to highlight a few things. So first and foremost, we can walk through sort of that, kind of arm in terms of where participants begin in the program. They're randomized to the intervention group or they randomized to wait list. You can see what happens during the active intervention or what happens during that sort of usual care waitlist group time. At 16 weeks, we stop medications and the coaching check-ins continue and what we're looking for in terms of our outcomes, which is on a subsequent slide. The bottom box also highlights that through this period, we're also examining implementation evaluation. So this is going hand in glove with effectiveness, but also implementation as we've designed this as a hybrid type 2 implementation evaluation. The far right corner orients you to the inclusion criteria. The inclusion criteria is based on, again, it's informed by the previous evidence base of the previous REMIT trials. But what's most important that I want to highlight here is this did indeed start off as your classic randomized control trial where, at a flip of a coin, someone got the intervention and someone got control or usual group. We had many, many discussions with our community partners, our primary care partners, and our patient partners about how precedent setting this was and how they did not want to be losing that opportunity to participate. So rather than being a classical control group, people are waitlisted so that ultimately everyone will get a chance. The question is when. And so in terms of the outcomes, we're using the Remit Prime platform, if you will, in terms of primary outcomes. And that is the likelihood or the hazard ratio for relapse. So it can be an A1C level that's above 6.5% or equal to. It can be glucose levels that are regularly over 10 millimoles per liter, looking at, about 50% of the time, or the use of or the requirement of going back on glucose lowering drugs. The additional secondary outcomes, some of them are the clinical, and what I mean by clinical, the kind of classic clinical outcomes that we inquire about, especially when it comes to metabolic changes. So we do look for weight and BMI, but we're also looking at the proportion of participants who have relapsed. We're also very curious about some of those correlates or things that can explain what we're seeing. So is it, income? Is it gender? Is it other variables in terms of demographic data? And then ultimately quality of life. So we are using the EQ5D, which is certainly a quality of life tool that was used in the previous REMIT trials. And then, of course, what's interesting and novel about this being an implementation study is that this is all informed, and we will be collecting insights about implementation informed by the CFIR framework, but also the intervention scalability tool, the ISAT. And so what we hope to do, we've had a little bit of a delay in terms of starting, but we now have a very passionate, enthusiastic group, a small and mighty team at Escarpment Health. So we are completing our implementation assessment, starting up with the REB sort of proposal to go through and going through the process of hiring and training the health coach who will be trained through the continuing professional development health coach training offered at McMaster University. And we look forward to embarking on year 2 where we're actually delivering the intervention and year 3 where we do sort of the follow-up implementation assessment. And all of this is really trying to understand the assessment of the feasibility, but the accessibility. Can this be delivered in primary care? And so what's really interesting is we wrap up our implementation interviews. I'm going to use a quote that's attributed to Jimi Hendrix, and that is, "Knowledge speaks, but wisdom listens." So we see the dartboard again. And I think this dartboard really depicts the beauty of what we're learning in implementation as it relates to diabetes remission and remit prime. So by engaging and listening with our patient and our provider partners, we've co-created an implementation plan that's going to stick. It reflects their reality, not the clinical reality that is coming from, sort of a tightly controlled, randomized control trial. We've learned pretty quickly that according to our patient and provider partners, that everyone gets a shot at trying to hit the bullseye. So we've revised the protocol to include that waitlisted approach. The other thing we've heard pretty quickly is that the Remit Prime protocol is based on numerous trials. It's been tried and tested, but it's also maybe an opportunity to kind of refresh the nutritional and the physical activity aspects. So the nutrition part really came out loud and clear from our provider partners, particularly nurses and dietitians and our clinical pharmacists. And so what did we do? First thing we thought was, okay, we have to update the evidence. Let's take a look. We certainly looked at the guidelines, but we also looked at updating other evidence. So we set the bar high. We looked for, arguably the best tool that we have in medicine, and that is a randomized control trial. It tells us, does this work in this population under certain circumstances? So we assembled a panel of experts. And again, this is where Diabetes Action Canada was certainly helpful in kind of pulling out the Rolodex, whether it was Kathy Whiteside and Tracy McQuire, linking us to networks where we've been so thankful with connecting with Kathleen Chouinard out in BC to just get a sense of what's important to people across Canada, whether they are people with lived experience, other clinician researchers, primary care providers, caregivers. What are some of those important aspects that we need to consider with diabetes remission evidence? So we looked at the PICOs, setting up those searchable questions and criteria. We searched the databases. We had that advisory group also look at ranking outcomes that were important for us. So number one, it signals, are we examining all relevant outcomes? And this could certainly lean into, triple aim, quadruple aim when we talk about complex interventions. Is it helping clinical outcomes? Is it meaningful for patients? Is it meaningful for clinicians? And is it cost effective as well? But the second thing that this really signaled to us was, what could we meta-analyze from a methodological scientific approach? So as we uncovered the literature, we found just over 17,000 citations. We screened those down. We found 16 trials that met that sort of high threshold of randomized controlled trials. Half were non-pharmacotherapy, so that kind of nutrition, lifestyle-based approach with physical activity, and the other 8 were multimodal in nature. The degree of nutrition or the degree of physical activity along with pharmacotherapy was all variable. We extracted data on the characteristics of those included studies. We looked at the internal validity. Could we trust the science that was coming out, or the results that were coming out? The TIDER, REAIM, and PRISM are all frameworks that we use to understand the intervention. Is the intervention relevant, effective? Can it be implemented? Can it be maintained? And then PRISM speaks to sort of the broader, demographics and social demographics. And of course, then we ultimately meta-analyze data. And so what did we find? We found that the likelihood of achieving type 2 diabetes remission at any point using any intervention worked. We found that with multimodal interventions, people could go into remission interventions, and the risk ratio was 1.75. And for non-pharmacological interventions, this was quite a bit higher at 5.87. However, as we looked at that data and looked at long-term maintenance, what quickly waned was remission rates following non-pharmacological interventions. And so in discussions with our advisory panel, what we found pretty quickly was, what do those interventions look like? And we heard pretty clear and in a pretty resounding way, there was some pushback to some of those aggressive non-pharmacological interventions. And I think it goes without saying that, people do enjoy food. Do they want to maintain a 700-800 sort of liquid diet, calorie liquid diet for a period of time? It works for a period of time, perhaps. But is this maintained? Is it equitable? Is it accessible? So we really wanted to take a step back and think, you know what? I think there's more to this story. And so more to the story also meant leveraging a fantastic opportunity that was presented through CIHR, and that was a knowledge mobilization opportunity geared to, all things diabetes, whether there's type 1, type 2, prevention of type 2 diabetes, et cetera. So as we had this evidence update, we had this fantastic opportunity. And probably most critical was we had an engaged advisory group. We thought, this is a shot we have to make. We have to go for this. So with all of the partners on board there, Diabetes Action Canada, we had the leverage of the grant, Remit Prime. We put forward an application to really look at, is this an opportunity to sort of change the dialogue around type 2 diabetes remission, demystify some of the things that are out there? And sure enough, as we applied, we were successful in funding. Um, and so this funding opportunity resulted in a knowledge mobilization integrated care team, which are the original advisors. We engaged experts early, especially at Diabetes Action Canada. So recognizing that this was a knowledge mobilization grant, thought I knew a lot about knowledge mobilization, but clearly I didn't. And what was evident in the CHR call was that you needed a plan, and the plan needed to go beyond, we're going to talk to some people, we're going to do some presentations and some publications. So by engaging in the right experts early, and we didn't have to go far to find the right experts, it was at Diabetes Action Canada. Monica Kastner was just someone I really, really, truly leaned on and learned a lot from. And in fact, invited her, even though this isn't necessarily her area of diabetes remission or type 2 diabetes remission, she was keen to use this as sort of a test case for a knowledge mobilization plan. So we created the plan, we determined the impact, outcomes, and outputs, and more importantly, we listened through deep consultation around what that plan might look like. So we leveraged the advisory team from the reviews, we captured that in the grant, and as I said, this was successfully funded. The biggest thing I think that came out of this for me, and it's quite busy here, it's quite hard to read, but elements of this table on the right of your screen are actually in the knowledge mobilization plan or toolkit that's now available on Diabetes Action Canada's website. And as Tracy mentioned earlier, this was a presentation webinar from Dr. Monica Kastner earlier in February. So I would encourage all of you, even if the timing's not right to apply for knowledge mobilization or using that, read, listen, learn, ask questions, because that's how we elevate the science around this space. It's just not good enough to do publications and presentations. And so what we did was we really looked at leaning into this opportunity. So we created a bunch of posters for consideration at Diabetes at Diabetes Canada at the national conference. This was accepted for presentation as a poster. We basically highlighted to folks what was our plan. So our plan was to look at basically increasing the awareness and the uptake and exchange of current evidence as it relates to type 2 diabetes remission. And probably the biggest thing that came out of this was that there are new and other ways to get to or try to get to type 2 diabetes remission. We also wanted to increase the access to evidence-based resources. So democratizing this shouldn't be behind a paywall, firewall in a publication, or it shouldn't be sort of hidden in a forest plot where people have a hard time understanding and reading a forest plot. So we talked a little bit about our products and our plan. And what was really insightful was that with the help of Monica and Julie McCarskey at Diabetes Action Canada, one of the first things we did was we actually put the plan out in the public ecosystem. So at Diabetes Canada, not only did we highlight we're doing this work, we put our plan up for discussion. And so we sought feedback, whether it was the QR codes or just in sort of organic discussions with dietitians, nurses, clinical pharmacists, endocrinologists, et cetera. And so we sought feedback from the broader community, and it was absolutely inspiring what we learned, informative what we learned, and kind of like that saying goes, knowledge speaks, but wisdom listens. And so where are we to date? So to date, we've done multiple presentations, including to members of parliament. So thank you to Diabetes Canada and Diabetes Action Canada for that opportunity. I'm here today, so thank you again. We have a nutrographic, which is really quite cool. It's considered something that is more nutrition based, and it's under consideration for an award from one of our trainees, Paige Alliston, at the Canadian Nutrition Society. And of course, our work to date is to really, really leverage a fun, exciting knowingdiabetes.com website, which is an evidence-based website repository for all things diabetes, including, type 1, type 2, etc. And so I come back to the dartboard, And yet here it is again. Part of what we've learned along this journey, I sort of come back to the very start, and that is defining type 2 diabetes remission. What has really come out through all of this work, from our work with our patient and provider partners as part of the effectiveness implementation trial, but as part of the knowledge mobilization opportunity, is how are we defining success? What does partial remission look like? And what does complete remission look like? We have definitions, we know that. But what really stuck with me is one of our prolific advocates when it comes to diabetes remission is someone that went through one of our early remit trials. It was one of the SIDA trials. And this gentleman talks a little bit about, according to the research definition, he's a failure. He never quite got to full type 2 diabetes remission. However, he defines his journey as success. Although he didn't stay in remission, he didn't quite get there. His current journey is that he's on metformin. He was able to get rid of the second class of oral anti-diabetic agents that he was taking. He lost some weight. He's back to playing squash. And more importantly, he feels that he is empowered and engaged even more so in his type 2 diabetes care. And in his words, and I'm paraphrasing slightly, he has the tools, knowledge, and capability. He is resilient. And even if and what worries him more than anything is, had he not tried to go through a remission protocol, he worries that he wouldn't have those skills, tools, and capability to do it. And so, as we're all in the business of improving the lives of individuals impacted by diabetes, it obviously aligns with all of our ethos, or mission and vision and mission and values. We ought to remember this first and foremost as we look to expand type 2 diabetes remission in an equitable, accessible, and an approachable way that certainly prevents re-stigmatization and further judgment and scrutiny about people not hitting the target. In our patient partners' perspective and in his story, what really resonates with me is he hit the target. He didn't hit the bullseye, but he certainly hit the target. And so in terms of next steps, Remit Prime, we continue to implement that. And as I said, we have eager sites waiting, and we have a lot of enthusiastic partners along the way in Hamilton and Cambridge. We continue to mobilize the type 2 diabetes remission evidence. This is a growing field. So I think, if anything, we'd love to turn our reviews in somewhat of living reviews, that we can kind of turn to that and update that as we go. And we certainly want to continue these conversations and dialogues with people with lived experience, peers, colleagues, as this evidence will be iterative. And this reminds me, as I wrap up, of another epic scene with a dartboard. So I don't know if people have watched Ted Lasso, but this one hits home on a number of levels. So I leave you with this one pivotal dartboard scene. And this is the scene where Rupert is judging Ted. Ted's throwing the dart, but with the wrong hand. And this is where Ted Lasso basically tells him about the Walt Whitman quote, to be curious and not judgmental. And as Ted Lasso says, if we were curious, if only they were curious, the people that judged him, they would have asked a lot more questions. And in this field, with a rapidly evolving sort of evidence base, we have a tremendous opportunity to rethink and reframe how we care for people with early onset type 2 diabetes. So we have a lot to learn from one another, provided we stay curious. And so, again, I stand on the shoulder of many giants. Sorry, I didn't think this would happen. Wow. And then I think I'll just sort of leave it at that. And thank you, Diabetes Action Canada. I apologize, guys. It's been one heck of a ride. Thank you to Diabetes Action Canada for all of their support and sharing their Rolodex. Kathy Whiteside, Gary Lewis, Tracy McQuire. The elevated role and way of thinking about patient engagement and partnership is massive, and I have learned and continue to learn so much from Lindsay, and of course, knowledge mobilization through the sweetheart, Monica Kastner, and Julie McCarskey. So thank you, everyone.
Thanks, Diana. And I
I'll
must
stop
say,
sharing.
oh, that I regularly burst out into tears with no prompt whatsoever as well. So I appreciate it and thank you for the presentation. So now we have some opportunity to ask some questions, and this is a really open forum to ask questions to Diana about the research of Remission or her work with Diabetes Action Canada or her work outside Diabetes Action Canada, but just really understand the process and the partnerships that have evolved. So I see, Virginia, you've got your hand up, so I'll let you start.
Oh, I'm the lucky one. So congrats for your project. And I just want to say that to saw you cry, I can totally understand when you put your guts and your heart on something and a huge and amazing project. It makes you so human, and thank you for this humanity in your project. Uh, your presentation was very good. I missed the beginning of it, so I hope I did not miss what is my question about. Sorry, and I'm a little bit rusty in English as well. Um, I'm mostly a researcher for limb preservation, but I also identify myself as a citizen partner regarding pre-diabetes and obesity. Um, and when we're talking about diabetes remission and things like that, I'm always thinking about the weight of people, because we know that obesity is a huge factor regarding type 2 diabetes. And when I saw your little data you have regarding the remission, there is intervention regarding behavior, physical activities, but you took also data regarding body mass index. My question is, as we know, obesity is more than a body mass index, and as we know that we can be healthy in a larger body, there is a new definition of clinical obesity that have been published in the Lancet. I'm asking to myself, the main idea is to reverse diabetes. But did you take other data regarding obesities, such as the circumference ways the circumference of the belly? I don't know how to say that in English, but I know you understand. Do you take like impedance weight to see the body fat on the organs? Because I read some article, because I'm very interested about obesity as well and the impact, because I'm living as a obese woman, and 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 we know that the body mass index is not enough, but if you are able as a citizen to lower your body fat in your organ, you can reverse diabetes and reverse other health problem regarding obesity. So my question was precisely about, because as a citizen, I don't want to just be a body mass index. I want to have other metrics that demonstrate that I'm going in a healthy direction, and it makes me proud to know if I can reverse some condition. It's not only because of the weight, it's because of other things in my life. So it was like a question and a suggestion. I don't know, but let's discuss.
No, thank you, Virginie. Thank you for that very thoughtful question, and for your candor and sharing your experiences. I will say I will not begin to fully comprehend and understand and sort of disentangle type 2 diabetes and obesity. I think that it goes without saying there's complexity, there's associations, these are correlated. I do know that Herzl Gerstein is on the call. I won't put him on the spot. I will just say that what we were looking for, and I think whether it's obesity-related complications or obesity prevention, obesity management, we need tools that are readily accessible and available in clinical settings. And unfortunately, we still rely on BMI, we still rely on weight, we still rely on waist circumference. And so this may change, Virginie. So for example, if we talk to our clinical partners, they also want to consider and reflect waist circumference. Great. But how do we measure in a clinical setting, sort of the the non-alcoholic sort of fatty liver, around the organ, that's not something we can assess readily clinically. But to your point, I can speak to many colleagues, for example, at the Population Health Research Institute, that are very interested in biomarkers. The more we learn, the more we're curious, the more we ask questions and listen to folks like with your question, the more we're pushing the science. So whether it's biomarkers, a deeper understanding of that connection of obesity and type 2 diabetes, more precise interventions. How precise can we be in identifying who is an ideal candidate for type 2 diabetes remission, and even what approach, right? Not everyone can do an 800-calorie liquid diet. Not everyone prefers GLP-1s. So your point is well taken. I think I would just encourage you to keep asking those questions. And the more we keep asking those questions, the more we push the science and the more we evolve this discussion. That's about all I can answer at this point. Thank you. Merci, Virginie.
It was a super answer. Thank you.
Okay.
I see Lindsay has her hand up.
Quick
Oh,
comment.
no.
I see that Sarah has a question in the chat. I'll just add
Oh.
to this discussion that we partnered with Obesity Canada for a diabetes and obesity conversation that will be launching next week. And this was part of the conversation specifically with folks at the Durham Health Clinic, which are doing, that team is doing a lot of what Diana just said, actually asking their patients first what they are comfortable talking about, and then exploring conversations around how can we go beyond BMI in this clinical setting, knowing like this is what we have available to us, this is what we'd like to talk about, where can we land together on a conversation that's comfortable for the patient perspective, but also partnering with clinician researchers. There's some really interesting work happening there with Obesity Canada. So I just wanted to add that. And I know that Sarah has a question about short-term versus long duration diabetes in the chat, Diana.
Okay. Do you want to just ask your question, Sarah?
Yeah, Sarah, do you want to
Sure.
just ask?
Yeah.
Hi, Diana.
Hi, Sarah.
Can you hear? Oh, you can hear me. Great.
Yes.
Thank you for a great talk. It was really inspiring. I noticed that the eligibility criteria for REMIT mean short duration type 2 diabetes. So I'm wondering if there is anything known about opportunity for remission in longer duration diabetes, or if our evidence is still building, and therefore what the messaging is when this knowledge is mobilized, because it's such a diverse population.
Right. So great question. So this is basically coming from what does the evidence tell us? So if you recall, the REMIT Prime is taking the REMIT protocol, which is an evidence-based protocol that has been tested on hundreds of people across Canada, diverse communities from Halifax to Vancouver, etc. So we're kind of sticking with what works, what is evidence-based, and that was strict criteria in terms of who could come in. We had to start somewhere. And again, I'm not going to speak on behalf of Herzl. Feel free to come off, but I think off mute, Herzl. But at the end of the day, this is how we disseminate or mobilize evidence. By that same token, when we looked at the evidence review, this recent update, we certainly do see people with 8 years of type 2 diabetes, some with less. So I think the more we include the evidence, we're starting to get a bigger and more fulsome picture. I will say as well, one of the things we need to look at is the longer duration of type 2 diabetes. How likely are you to go into remission? So that is intertwined with sort of the physiology, maybe socio-ecological makeup, et cetera. But I see Herzl's on camera, so I don't know, Herzl, if you want to just maybe chime in there. Sorry to put you on the spot.
Oh, no, I just typed an answer. Superb presentation, Diana, and it's great to see everybody. No, the point for Sarah is that the only studies that have not looked at duration have been the bariatric surgery. So they've had very long-term diabetes, has had bariatric surgery, goes in remission, but most of the non-surgical studies have just been done in shorter-term people with diabetes because it's early days. And that's the lower hanging fruit. But, there's no reason that we can't do these studies in long-term diabetes. We want to get some successes first. And if bariatric surgery works in somebody who's had diabetes for 20 years, there is absolutely no reason to think that other therapies won't work in that population. But you got to start somewhere, and you want to start with some successes before you start doing it the people that you're not as sure about.
Thank you, Herzl.
Thanks both.
Well, oh, and I see one last question, and then we'll pass it over to Lindsay. So Akim.
Hi, thank you very much. Wonderful, Diana. It's a wonderful presentation and many items that you discussed. Truly life-based, truly demanding, and truly creates impetus for more scientific research. And still it's a gray area. Remission, managing diabetes, because there are multiple cofactors, co-founders for remission of diabetes. If we say remission, and again, there are differences about the definition of remission and what is the starting point and what is the measurement end point where we'll measure. Anyway, I'm not going there. So it would be helpful for me for actually to understand if you have done, perhaps you have done already, the percentage contribution of the physical activity versus medication, and then medication, oral medication versus injectable medications, meaning I want to mean Ozempic or insulin, because now it is the Ozempic day. So, and nutrition. Nutrition, I mean dietary. So in diet, there are two things: dietary habit and dietary behavior. And those are intersecting with the ethnic group. Like dietary behavior of some ethnic nations are not similar to others. So my question is again, that have you done, definitely you have done it, that is not a good question. So if you could share sometime, not now, right, not now, even we have the emails, so that percentage contribution of either of these factors, physical activity versus dietary contribution, that is lifestyle modification, versus medication, injectable, non-injectable. So then for the patient advice, for that would be very helpful, that we can say, yes, if you can go that way, give 40% importance on lifestyle modification, then you can reduce your medication that people don't like. Diabetic people, one thing that people don't like, that is medication. So you can avoid your medication. So that is, if you have done it, please. That would be.
Right. Thank you, Akim, for that question. I didn't share all of the meta-analyses and outcomes from the evidence update. So there's first and foremost more to come. What I will say is, at a very high level, when we looked at those two broad categories, multimodal that included nutrition, pharmacotherapy, but those that included non-pharmacotherapy, so it was just nutrition, physical activity, we saw that the likelihood of going into remission was far greater with non-pharmacotherapy, but it just wasn't sustained as well as, now. Then you have to ask the question, what did that look like? What was that strategy? And what we find is, so we didn't mathematically do any regressions. We didn't do that with the data because, number one, it's poorly reported in the literature. And then number two, we just don't have enough literature. We only have 8 studies, 8 trials that met the criteria. So time will tell. And this is why I was thinking we have to keep an eye on this and keep asking that question. However, one of the things that concerns me the most is that with many of these trials, people are put into very confined places, arms. So they're provided food, provided shakes, provided this. And so all of this, and they're remunerated for their time. So this is why we do implementation science. We take what we know from clinical trials and try to put it in real world practice. I think time will tell, Akim. The other thing I will say, though, is that medication is something that is very much dependent on the individual. Do I adhere to my treatment regimen? Food, far more complex. Who buys it? Who cooks it? Can you afford it? What about the cultural norms? What's your relationship with food? Do you have past trauma where your relationship with food is soothing? I could go on, but I think time will tell. Akeem, thank you. And we'll certainly reach out to you with our publications, and maybe there's something more in there as well.
Thank you, everyone. And in the interest of time, we're just going to move over to Lindsay, who's got a couple of closing remarks.
Thank you so much, Diana, and everybody for your questions. It's clear that everyone's keen to discuss about this, so thanks so much for presenting and everyone for participating in that discussion. I don't really know how 57 minutes just went by. That went so quickly. Thanks all for joining us for our first action session. A couple of next steps on our end. And I'm just going to put up my screen here. Actually, Tracy, can I ask you to, it's not letting me share my screen. Can I ask you to share that last slide? Brilliant. Thank you. So some next steps. We're going to summarize the discussion, send out a recording, the slides, but also summarize some key takeaways and hyperlinks to any resources, papers, tools that were mentioned here today. And anyone who's registered for the session will get that. You'll notice that in the agenda, we were hoping to present the DAC Community Hub to you folks, but I think this is your excuse to come to our next action session in May. We'll have some more dedicated time to talk about that patient-led initiative. And by the time we reconnect in May, there will be much more resources up there and more updates to share. Please stay connected with us, not just through these sessions. Follow us on LinkedIn. Stay tuned to your inboxes for our newsletters. And if you have ideas for collaborations or ways that we can support your work, reach out via email, reply to the summary email that we're going to send out from this event. We're here to help and we're here to support. And save the date. We're going to have our next action session on May 29th. We'll be planning what kind of presentations we'll have next time, and let us know. Is there something particular that you want to hear about, that you want an update on, something that would be most useful to your work and your projects? We're here to support and illuminate your work and help spread and scale the amazing things that you've been doing. With that, thank you so much for joining. We wish you snowy but safe afternoons, and we look forward to seeing you very soon. Take care, folks.
Bye, everyone, and thank you for coming.